Hi, good morning, everyone. Myself, Dr. Sudhakar. I'm working as an assistant professor in Department of Radiology in Sri Lakshmana Medical Institute of Medical Sciences, Pondicherry. So today we'll be discussing about the importance of CT dose and the methods to reduce the radiation dose to the patient. So our topic of discussion today is CT dose reduction. So we're going to discuss this topic under the following subheadings, which includes CTDI volume, DPL, effective dose, ALARA, factors influencing dose reduction strategies like automated tube current, then automated tube potential selection, iterative reconstruction, specific protocols in certain specific individuals like pregnancy, lactating mothers, and pediatric. So the patient specific, as I said, for pregnancy and pediatric and cardiac CT in pediatric and also in adult. As you could see, this is a young adult patient who came for CT whole abdomen plane. So for any such type of CT scan, we always arrive at a report like this, which is given by the CT machine. So in this, you can see there is something called CT dose index volume, CTDI volume, and DLP. So as you can see, the CTDI volume for CT whole abdomen is standard for almost all patients. However, the dose length product is related to the length of the patient and length of the scan. So these are the two important parameters which helps us to assess the radiation dosage to the patient. So CTDA volume, it is nothing but a measurement of radiation delivered from a series of contiguous irradiation to a pair of standardized acrylic funnel. It is measured from one axis CT scan. So this accounts for gaps or overlaps between X-ray beam from consecutive rotations of the X-ray source. The SI unit of CTDA volume is milligyre. It is a standardized measure of radiation in the CT environment. So CTDA volume directly proportional to the MAS. The effective MAS is done in the helical, so which gives us kV value. So CTDA volume increases exponentially when the tube current is increased. So what is dose length product? It is the CTDA volume which is integrated along the scan length to compute the dose length product. So obviously the unit of dose length product will be milligyre centimeter. CTDA volume times the scan length. So it reflects the integrated radiation output attributable to the complete scan acquisition. Thus, it tells us about the potential biological effect. Example, abdomen only CT and abdomen pelvis CT examination might have the same CTDA volume, but it will have a greater DLP in case of abdomen pelvis because the scan area is increased when compared to the abdomen only CT. What is effective dose? That is a concept which reflects the stochastic risk. Its unit is 1 milligauge or 1 millisievert. It reflects radiation detriment averaged over gender and age. The European Working Group of Guidelines on Quality Criteria in CT proposed a generic estimation method for effective dose. So effective dose is equal to dose length product into region-specific K coefficient. However, the effective dose alone does not give a complete picture of the estimated radiation risk to specific radiation sensitive organs or patients of a specific age or gender. So it is mainly used for the quality control assessment. So as you could see in the example, so in a case of adult patient who has undergone CT head, the CTDA volume is 60 milligauss, right? Whereas the dose length product is 1000 milligauss per centimeter. So the effective dose in this patient comes around 2 millisieverts. Whereas for a 1-year-old child, same head CT will result in CTDA volume of 30 milligauss and dose length product of 360 milligauss, which results in an effective dose of 1.8 millisievert. So you could see the effective dose is equal to the DLP into region-specific K coefficient. So since there is variation in the K coefficient and CTD and DLP in a 1-year-old child, the effective dose is 1.8 millisievert and compared to an adult CT type. So how this standardization is done? So usually this is use a appropriate phantom to verify for the quality control assessment and annual report submission. So 32 centimeter body PMMA phantom is used and 16 centimeter head PMMA phantom is used. So basically, any pediatric cases, they will use the 16 centimeter as the standard. So there are a few recommendations which we have to know about. The first one is the International Commission on Radiation Protection, ICRP recommendations. So ICRP 60 on 1991 and ICRP 103 on 2007. This must be provided when a value of effective dose is given. So next we come to an important topic called ALARA. So any CT, any radiological imaging which includes radiation exposure should follow the ALARA principle. So what is the abbreviation of it? It is as low as reasonably achievable. So justification. So first thing is you should justify that the imaging method, imaging modality or CT or X-ray, whatever it is medically indicated for the individual. Then optimization, which is performed using doses that are ALARA consistent with the diagnostic test. Then limitations, occupationally exposed individuals, it's very difficult to use these ALARA principles. So guidelines, so these are the referrals. The most important and most followed thing is the American College of Radiology appropriateness criteria. The other two include European Commission guidelines and UK referral guidelines for imaging. So we'll be talking about the factors influencing the patient base. So the first thing is KV, second is MAS, then rotation time, reconstructed slice with helical or axial acquisition, pitch, which is very important, then number of detectors, rows, reconstructive algorithm which is used, then FOV, field of view. So the influence of operator selectable parameters on those is of a main concern. Selection of scanning parameters is interdependent. In addition, the dose depends on scanned length, both protocol and patient dependent and patient built. So dose reduction, so X-ray beam energy, so effect on radiation dose. In X-ray beam energy, higher energy increases the radiation dose. The tube current, higher the tube current, the more the radiation dose. And gantry rotation, faster the gantry rotation, reduces the radiation dose. Selection or section thickness, thinner the collimation, it is, whenever the collimation is very thin, the dose is increased. And pitch, higher pitch reduces the radiation dose at matched tube current. The distance of X-ray tube at CT ISO center. So the optimal patient placement decreases radiation dose. Scan length, lengthening the scan range increases the radiation dose. Dose reduction strategies, so easy implementation strategies and moderate to difficult implementation strategies are available. So first thing, to check the CT appropriateness, whether it is significantly essential in that particular individual. Minimize the scanning coverage, minimize number of acquisitions. So moderate to difficult implementations include reduce peak kilovoltage, reduce tube current, optimize patient centering, standardizing the protocols across scanners. And the more expensive ones include vendor-specific hybrid iterative reconstruction techniques. We'll be talking about in the further future coming slides. Then model-based full iterative reconstruction techniques. That is the most expensive one, and it is the moderate to difficult implementation factor. So AEC, so automated tube current modulation and automated tube potential selection. What is automated tube current modulation? The MAS and rotation time are taken together as MAS per rotation. So MAS is directly proportional to the dose. So whenever MAS is increased in those parts of the body with greater attenuation, for example, shoulder, because you need to diminish the soft tissue factors in that area, AEC software can reduce radiation dose up to 40 to 50%. Patient size, AEC, determined by the topographic image of the patient. Then Z-axis AEC, it adjusts along the length of the patient. Example, in thoracoabdominal CT, image quality in thorax and abdomen should be identical despite the attenuation difference between the thorax and abdomen, which is an air-filled compartment and the solid organ structures. An angular AEC, which modulates as the X-ray tube rotates 360 degrees around the patient along the XY plane. Combined X-Y-Z axis, this is similar in almost all vendors. Strength of modulation varies in this. The second thing is automated tube potential selection. So decreasing the KVP, extremely efficient means of reducing the radiation exposure. As the radiation dose changes roughly the square root of the tube potential. With a constant tube current, decreasing the tube potential, for example, from 120 kVp, which is a standard, to 100, dose reduction of 33% can be achieved. From 120 to 80 kVp, dose reduction up to 65% could be achieved. But it has its own demerits, which we'll talk in the next slide. So as you could see in this thing, there are two images A and B. Both are of CECT abdomen of a same patient. So the first study is done using 120 kVp and the second study is done using a 80 kVp protocol. So as you could see, the enhancement, mucosal enhancement of the bowel wall is seen in this clearly. However, when you compare it with the 80 kVp, 80 kVp shows much sharper and better enhancing images when compared to the 120 kVp. And the radiation dose difference is very significant. As you could see in 120 kVp, it is around 13 milligauss, whereas for 80 kVp, it is only 5.5 milligauss, despite getting a adequate diagnostic quality image. So this is the one important factor which I want you guys to remember. See, as the kVp is decreased, the attenuation of iodine increases, even without a change in the dose of contrast administered, by improving the tissue contrast in the image. However, if all the other factors are kept constant, decreasing kVp alone causes increasing image noise. So this was the demerit which I was talking about. So whenever you reduce the kVp without altering the other parameters, you have an increased image noise. I'll tell you what is that increased image noise. So whenever the kVp is reduced, MAS must be increased to preserve the image quality. As you could see, there are two images A and B, both are of coronal post-contrast CT abdomen of which is showing the contrast opacification in the abdominal aorta and its branches. So the first image, it is done under 100 kVp, whereas the second one is done in 120 kVp. So there is no significant adjustment of tube current. MAS is done. As you could see, the image noise is in this image is significantly more. So what is image noise? As you could see, this image is much sharper and clear. Look at this interface between the subcutaneous fat, skin, muscle, and the peritoneal fat and the other solid organ interfaces. Whereas here it is little blurred and it is not as sharp as compared to the image which is done under 120 kVp, which is the standard. So this is the issue with reducing the KVP without altering the other parameters like MAS. So whenever you reduce the KVP, MAS has to be increased. So every individual CT manufacturer has their own specific name for this AEC. So in Siemens, it is called as CARE KV. In Philips, it is called as dose right, and in GE, it is called as auto ME or smart ME. So these calculates the optimal tube current and tube potential depending on the type of study, body region, and patient's body habitus based on topographic image. So there was a study Winkler et al. In which CT scan of 40 patients were done, and all were found to be of diagnostic quality with an overall 25% reduction in radiation dose compared with the standard 120 kVp protocol. So the maximum dose savings are seen specifically in the CT angio or any contrast CT studies. Reduced kVp brings the tube potential closer to kH of iodine. That this increases the attenuation of iodine within the vessels with well-preserved contrast noise ratio. So there is significant reduction in patient dose can be achieved. Then lesser degrees of dose reduction in conventional venous phase and non-contrast studies because lowering the KVP needs compensatory increase in MAS. So reconstructed slice width. In a single slice scanner, patient dose is generally independent of the width. CT day volume does not vary with slice width. Integration is normalized to slice width. Therefore, the DLP should remain constant. Example, a 200 mm long region may be scanned using 20 rotations with 10 mm slice width or 100 rotations with 2 mm slice width. Slice thickness does not increase dose is to emphasize that this is only if the MAS is not changed. So as a general rule, use of narrower reconstructed slices is associated with an increase in dose, but this is not due to slice thickness per se, rather it is due to the associated increase in the MAS. So choice of helical rather than axial, it is done mainly because of this reason. This does not influence other than the small amount of overscanning at the start and the end of the scan. Increase in dose is equivalent to an additional rotation of the gantry. So in axial scans, as you could see, there is a gap between every sections or every slice which is taken as an image. So it just scans, stops, moves, and scans again. Whereas in case of helical or spiral CT, so it starts and it continues the imaging process without any gap of stop anywhere in between. So the pitch is the one which plays a major role in this helical CT. So in a single slice helical CT, pitch is equal to tabletop movement per rotation by collimator width at the isocenter. Whereas in a multi-slice CT, pitch is equal to tabletop movement per rotation divided by the detector length. So few vendors use detector pitch, which is table movement by detector width. So pitch with values more than one implies that there is a gap in data collection, whereas pitch less than one implies there is an overlap or overscanning being done. So this implies the standard pitch is 1, which most of the places use. So although CT around 360 degree are typical, it is minimal to produce adequate CT image is a scan of 180 degree. This implies upper limit of pitch should be about 1 by 0.66 or 1.5. So dose, this is very important for you guys to remember. So dose is inversely proportional to pitch. The use of a pitch of 1.5 rather than 1 leads to a 33% of dose reduction. Number of detectors and reconstruction algorithm. Number of detectors used has no influence on dose, nor is there any direct influence of the reconstruction algorithm or the FOV. However, both of these do influence noise and image quality with influence of MAS. So iterative reconstruction, it is a form of reconstruction where images being printed or images being formed in a CT machine. So all these things are like software which is included in the CT machine, and we have nothing to do manually. So reconstruction methods are based on FBP. The algorithm underlying the FBP is an approximate mathematical relationship between the projected data, the data displayed in the final CT image. Only at high radiation doses, a situation in which noise is relatively diminished, the FBP removes only a limited amount of noise. This would limit the use of data with low CNR, and this results in greater radiations. Iterative reconstruction. So each vendor have a different algorithms, but with same basic premise, trial and error algorithm using a correction loop. In simpler terms, see, every software of this thing CT vendors has a comparative image. For example, if it is CT brain, they have a comparative image inbuilt into the software. So whenever a CT brain is done, so it keeps on this iterative reconstruction or any FBP or anything, whatever the imaging method is there, it will just keep on comparing to the standard image which has been installed till the deviation is to an extent of acceptable level. So which is time consuming, and the correction loop rectifies that. These loops can be performed both in raw data space and in image space. Various vendor uses this space in unique fashion, and a few hybrid reconstruction has come, which includes both iterative and FBP. This serves two primary purposes. One, reduces the reconstruction time. Then iterative reconstruction images appears much smoother where FBP for used for sharpness. So in GE it is called as ASIR. So in Siemens it is Sapphire, and in Philips it is IDOS. So now we'll talk about the specific protocols. So first, regarding the small changes, main thing is indications, then coverage and required phase, whether it is arterial venous delayed or only arterial venous is enough. So first thing is to know is the clinician should discuss with the radiologist whenever they require a CT imaging for an individual patient, especially the contrast study. Because we have different protocols for different indications for different patients, so it could be tailor-made for particular patient. So it's always advisable to discuss these things with the radiologist so that the tailor-made protocol could be arrived for that particular patient. So as you could see in this thing, so it is an 82-year-old old man with post-aortic stenting been done, and it is a post-contrast CT abdomen with MIP projection. Other than first post-operative CT, post-stent graft CT examinations are done with reduced coverages from just above the stent to pelvis, reducing the dose by at least 50%. So this is not the first post-operative scan of the patient. So whenever there is a second and further post-operative scans for stent replacement of aorta and such things, the area of field of view which could be included are 5 centimeter above and 5 centimeter below the level of the stent. So this much is enough. So basically the coverage is reduced in this patient, which helps further to reduce the radiation dose to this patient. Then reducing the tube current and peak kilovoltage. Some studies can tolerate more image noise like renal stone, angiography, and coronography. So divided into low contrast lesions like liver mets or pancreatic cancer, or high contrast diseases like angio and enterocolitis. So large changes are denoising and iterative reconstruction, which we have talked in the previous slides. Iterative reconstruction, FBP, or hybrid systems, which has been used. For example, ASIR in GE, Sapphire in Siemens, IDOS in Philips, and AIDR in Toshiba. So the specific protocol, CT enterography. So it is this study which helps you to visualize the bowel loop and the mucosa of the bowel, mainly done in cases of IBD like Crohn's and ulcerative colitis. So instead of that, MR enterography can be done if the patient is less than 30 years old or if the patient is a known case of Crohn's disease. And reduced coverage if patient is less than 30 years old, which includes only the small bowel, excluding the lung base, diaphragm, and top of the liver. So three-phase urogram, unenhanced nephrographic and delay. So split bolus technique is the one which can be used to reduce the dose. It is nothing but So, for example, if the required contrast for a CCTKB is 80 cc in a patient, you could split it into 40. The first 40 cc is given before the start of scan. Then the second 40 cc along with 20 or 30 cc of saline rush through a power injector can be done at the time of scan so that we can get only the plain CT and the two phases which include nephrographic and delayed. So basically we are skipping the cortical phase in this thing which is done in routine CCTKB. So by this way, we are reducing one CT protocol phase that's helping in reducing the radiation dose. And CT colonography, as mentioned earlier, reducing the coverage to cover only the colon. Then post-graft stent, which we saw in that previous image. So cover 3 centimeter above and below stent only on 3 faces. Triphasic liver CT, clarified indications like HCC, cholangiocarcinoma, indeterminate liver mass, not used to rule out metastasis, fatty liver, elevated liver enzymes, do not routinely include the pelvis. In case of biphasic liver, CT primarily for evaluation of hypervascular liver metastasis like carcinoid, renal, and melanoma. Renal stone CT cover kidney, bladder only, except if ordered from the emergency department for a suspected case of acute abdomen. So lung cancer follow do not routinely include pelvis unless it is specifically requested. So patient specific. So the most important factor which we're going to talk about is, so what about a pregnant woman? So in pregnancy, obviously the potential effects are there, which includes prenatal death, IUGR, reduced IQ. Indications are appendicitis, pulmonary embolism, renal or ureteric calculi. To determine if the necessary diagnostic information can be obtained from any alternative imaging method, if non-acute, kindly postpone the study. So for the first thing, always check whether the suspected clinical diagnosis can be confirmed using another modality like ultrasound. If it is not been done with ultrasound, so always you calculate the risk versus benefit ratio in those individual patients. The most common referral of a pregnancy women include RAF and lower abdominal pain. So with a suspicion of appendicitis. So in that case, scan volume can be restricted to the necessary anatomy, which covers only the RIF. The dual studies should be avoided. And contrast could also be possibly avoided in such cases. Then ureteric or renal calculi, so low MAS, high pitch, and a limited scan range without compromising the study quality should be done. Abdominal pelvic CT, the scan parameters such as wider beam, collimation, higher pitch, and low MAS, AV, and the scan range can be done. So it is selected to reduce the fetal dose to 23 milligauss per scan per phase. Even for a routine dose level biphasic CT, abdomen and pelvis, probability of birthing a healthy baby decreases only by 0.5%. So these things you should remember, because even in a biphasic CT abdomen pelvis, which is done routinely without any alteration or without any tailoring, the probability of birthing a healthy baby reduces only by 0.5%. Okay. So next, so the contrast most commonly used for the CT is iodinated medium, which has a low risk of adverse effect. Which includes nausea, vomiting, flushing, pain at injection site, and anaphylactoid reactions. Although iodinated contrast media can cross the placenta and either enter the fetal circulation or pass directly into the amniotic fluid, animal studies have reported no teratogenic or mutagenic effects from its use. Additionally, theoretical concerns about the potential adverse effects of free iodine on the fetal thyroid gland have not been borne out in human studies. Despite this lack of known harm, it is generally recommended that contrast only to be used if absolutely required to obtain additional diagnostic information that will affect the care of the fetus or woman during the pregnancy. So the next important thing is lactating women. a lactating woman who receive intravascular iodinated contrast have been advised to discontinue the breastfeeding for 24 hours. However, because of its water solubility, less than 1% of the iodinated contrast, which is administered through IV in a lactating woman, is excreted into the breast milk, and less than 1% of this amount of contrast will be absorbed through the infant's GI tract. Therefore, breastfeeding can be continued without interruption after the use of iodinated contrast. So this is the clinical guideline which is given by ACOG. So I would like you guys to go and visit this article for further detail regarding the pregnant and lactating women. Second most important thing is in pediatric patient. How about in pediatric cases? Obviously, they're not as like an adult individual. So we need a proper tailored protocol for these patients. And the risk of cancer in children caused by radiation is 2 to 3 times higher than an adult. The best way to reduce radiation dose is to avoid unnecessary CT examination and to look for alternative diagnostic imaging like ultrasound or radiograph, fluoro, or whatever. The recent protocols usually include tube current modulation, child size, bow tie filter, weight size technique chart, which can determine the appropriate KV or MAS. So helical CT in children. So all these things started in 2001 when an article in USA Today published based on the AJR journal raised the public awareness that routine CT have potential to cause fatal cancers in children. So this was the article. It was titled as B-Wise Adjust for this size. Then after this been published, the Society of Pediatric Radiology organized a meet to address this concern. So in 2002, few guidelines were established for performing MDCT in children's. In 2009, Image Gently campaign was arranged by American Society of Radiologic Technologists. And later, there was an introduction of a smart card by International Atomic Energy Agency by 2012-13. So this is the smart card. So it is the card which has the information regarding the radiological examinations which was done previously to that particular individual patient and the radiation dose or exposure which has been done to the patient till date. So this is very important, and it will be like still it is not available in India. So it is like if we get this kind of smart card in India for this radiation dose assessment in every individual, so it will be really helpful for the radiologist and the clinician to tailor the protocol for that particular individual. So cardiac CT in pediatric. So non-ECG gated, retrospective and prospective ECG gated helical CTs are there. So in non-ECG synchronized helical CT, effective dose is less than 1 millisievert. So you examine the heart and the origin of great vessels in congenital heart disease. Whereas retrospective ECG gated helical CT, addition to the morphological changes, you could also know about the functional evaluation of the heart. ECG control tube current modulation. So effective dose should not be more than 2 to 6 millisievert. So whereas in prospective ECG gated helical CT, this is the lowest radiation CT, so which include 0.2 to 0.7 millisievert in newborns and infants. Even if a non-breath hold technique is used, the images are often motion. The main disadvantage is lack of functional assessment due to limited data acquisition during only a portion of full cardiac CT. The cardiac CT in adults, dose in cardiac CT is more complex. Two reasons. One, dose, noise, and pitch have different relationship in cardiac CT. Dose in cardiac CT depends on patient's heart rate. So in non-cardiac MDCT, the noise depends on the pitch, whereas in cardiac CT, the noise depends only on an MAS. Only partial amount of the projection data from the rotation is used for image reconstruction. So as I mentioned, dose is directly proportional to the MAS. There was a study, Akenbeck et al., where maximum organ dose value during a cardiac CT is as high as 50 to 100 millicurie. No dose reduction measures are taken. So important dose reduction tool is ECG-based tube current modulation. So ECG-based tube current modulation is this one. The width of the temporal window having the maximum tube current, excuse me, can be selected by the user, whereas the temporal width of the image reconstruction window is fixed. For full quality images, the reconstruction window, that is the darker gray time interval, as you could see, reconstruction window should fall within the maximum MAA window. And these are done between the RR interval, that is the each cardiac cycle, within each cardiac cycle. The percentage dose reduction is higher for patients with slow heart rate because the maximum MAA period is a smaller percentage of the time interval between successive R waves in the ECG at low heart rate. So there is a study called Westing et al. An optimal window for ECG-based tube current modulation is used. In a case of low HR heart rate less than 65, it is 60 to 76 percentage. In intermediate heart rate where 66 to 80, 79 beats per minute, it is 30 to 77, and high heart rate more than 80, it is 31 to 47 percentage of dose reduction. What about an irregular heart rate? Some system automatically increases the tube current to the maximum level when a statistical trend analysis algorithm recognizes an RR interval that is significantly different from the previous limit. The role of AEC in cardiac mode, it is limited to automatically adjusting the MAS values, and it cannot be combined with other type of modulation and compared to the other body CTs. Further dose reduction can be achieved by using lower kV, which is 80 or 100 kV. Additional dose reduction by prospective ECG triggering step and shoot can be done. So prospectively triggered dual CT allows for the accurate diagnosis at a low radiation dose in a patient who have a regular heart rate. Very important to remember. So occurrence of artifacts due to ectopic beats is reduced using adaptively triggered sequential scans. Triggering for each cardiac cycle is adjusted according to the ECG trend and variations. So to conclude, optimizing the radiation dose prescription is challenging because examinations with elevated radiation exposures gives very acceptable images. To understand one thing, always the clinicians require adequate diagnostic quality images. So it is the responsibility of the radiologist to discuss with the clinician, to sit, discuss with them, and properly tailor the protocol for every individual based on the requirement. And always remember the initial step is to know whether, initial step is to decide whether that radiograph imaging method like CT or X-ray is essentially needed for the patient for the diagnosis of clinically suspected condition. Look for any other non-radiation alternatives like ultrasound and always discuss this with the clinicians. So optimizing the radiation dose prescription is challenging because examinations with elevated radiation exposure always gives a very acceptable image. Then optimizing the right minimum dose for a range of patients' size is difficult, and it requires attention to all the tools of the dose prescription, which we have discussed. And to satisfy the ALARA principle, radiologists should be familiar with CT appropriateness parameters, optimizing the CT protocols, tailoring it for every individual patient, just to minimize the radiation for their patients. So these are my references. So the main references include strategies for reducing the radiation dose in CT and CT dose reduction applications, the available tools to the latest generation of CT scans. And one more thing which I forgot to tell. So regarding this heart rate, we were talking about the tube current modulation. So recently, we have got AA-assisted cardiac CT, which doesn't depend on the heart rate. So whichever heart rate the patient has, the AA adapts the current modulation according to that, and you don't need any beta blocker or anything to bring the heart rate to the required range. So in summary, so remember these things. So scanner output, which mainly depends on CTD and TPL. Then effective dose, ALARA principle, which is very important, and factors influencing the radiation. Dose reduction strategies, which mainly include automated tube current modulation, modification, which is MAS, and automated tube potential modification, which is KVP. Then this iterative reconstruction and FBP or the softwares which is installed in every CT vendor machines. Then specific protocols, specifically which we discussed include pregnant women, lactating mothers, pediatric patients, pediatric routine CT, pediatric cardiac CT, and adult cardiac CT. So the patient specific, which include pregnancy, pediatric, and cardiac CT was the one which we discussed. And remember this smart card. So it will be effective if it is established in India. So this is the smart card which we have talked about. Thank you.